So my task is to look at management of multiple myeloma, where we are and where we're going ahead, where we should be going in future. So we're looking at some landmark trials. What are the approved drugs? What are the landmarks in multiple myeloma? How we're moving on from triplets to quadruples? What are the new guidelines in a newly diagnosed multiple myeloma patients in transplant eligible and non-eligible? And what are the treatment options in relapse refractory setting? And we would go into the antibody-based immunotherapy. What is the role of supportive care and novel agents in the pipeline, including a nanotherapy? What are the new anti-myeloma strategies? About CAR T and BCMAs, and what is the role of precision medicine in this heterogeneous clonal disease. Next slide, please. So the reason for that, we still have an unmet need because the number of cases are increasing over the last decade. In year 2020, according to Cancer Population Registries, the total number of new cases are 21,000 in India. Next slide, please. So where we are, let's look at the landmark trials and move on. Next slide, please. So this is an FDA approved, a very busy slide, but it tells us the landscape of how we have done from 1960s, 70s to 2020. In the beginning, if you can just see the slide, it took a longer time for the new agents to come. From 1960s, we had a Malfolon and Pred, and even the auto transplant came in 1980s. The role of auto transplant has been established. And thereon, the new trials showed a Malfolon to and prednisolone addition of thalidomide. That's the first time started up with the triplet agents, followed by 2003, which after a long time, we had the new drugs with bortezomib, followed by lenalidomide and the doxorubicin role. And it took a couple of years again to have a newer agents. That is in 2012, we had an FDA approval with pomalidomide and carfilzomib. In 2015, it's a big time for multiple myeloma. We had enormous amount of new drugs which were approved: Daratumumab, ixazomib, elotuzumab, and panabinostat. And Dara has really changed the landscape of multiple myeloma, how we're going to treat from now on, and the future is going to change. And 2018, we have approval for denosumab, and 2019 with the selinexor. And 2020, we had two new agents, that is isatuximab and also belantamab. This is a CD3, a chimeric monoclonal antibody. Next slide, please. So these are the landmark trials when we have established the consolidative confirmed role of autologous stem cell transplant, that is from MRC7 and IFM90 trials. And if we look at IFM94 trial, this is how these trials are the ones which have confirmed the role of autologous stem cell transplant. Mind you, on those days, we've been using triplets or at the maximum doublet agents. People had VMP or MPT as the initial or Valcadex prior to the transplant. So the role of transplant is slowly changing. We will come to that at a later date. Move on, next slide, please. So again, the newer agents, the landmark of thalidomide approval with Italian Gamema trial and IFM 9906 trial, and bortezomib and dexamethasone, a randomized trial, have given approval in 2003. According to the APEX trial, and multiple myeloma 010 and MM009, which is given approval for lenalidomide when they've tried against dexamethasone as a single agent. Move on. So from the single agents, we've come to double agents by 2013, where fell on with a myeloma 11 trial. We went on to triplet agents. If we look at the key milestones with the daratumumab in 2015, it's approved as a third line agent in combination, which went on to have a role after one failed regimen. In 2017, multiple myeloma patients who had received at least 2 previous lines of therapy, including lenalidomide, were approved, and the combination was approved in 2017 with pomalidomide and dexamethasone. But in 2018 onwards, the landscape is changing. The Dara is coming on to a newly diagnosed patients who are ineligible for transplant. They could have a combination of VMP with the daratumumab, which is FDA approved. Following in patients who are transplant eligible, we had a VTD in combination with the daratumumab approval in September 2019. So in transplant ineligible patients, daratumumab approval is with a VMP and Dara with lenalidomide and dex. In a transplant eligible patients, It is with a VTD along with the Daratumumab, according to the FDA. Next slide, please. So how did we get the approval of Quadruplet clinical trials? There are quadruple therapy of DARA combinations. There are multiple trials looked at this. Just few of this clinical trials are Alcyclone, Cassiopeia Trial, and Griffin Trial. Most of us are aware of, and Master Trial. Next slide, please. So each trial is looking at a combination with the different ones. Alcyclone trial is a DARA VMP versus VMP, which was first in transplant ineligible elderly patients. This has been tried, and it has shown a significant PFS and overall survival, and this has been approved now in a newly diagnosed upfront myeloma patients. Next slide, please. So these are the changes in a PFS from 19 months to 36 months, and overall survival, it has still not reached. So the curves are still plateaued. Move on. The Griffin trial tried a VRD with Daratumumab versus lenalidomide and dexamethasone. And then in this trial, there is a significant difference in PFS and overall survival as expected. But this combination has not been approved. There are two drawbacks: that it's not been tried head to head. The DARA VRD versus VRD has not been tried. So it is sort of a non-inferiority trial. And also there's an increase in toxicity, and there's a little concern about unable to collect the stem cells for transplant, but it's still in the pipeline for approval. And many of the US institutions use this now as an upfront regime in transplant eligible patients. Next slide, please. So this is the response rates with overall survivals. Next slide, please. So Cassiopeia trial, I think it's a very important thing because the VTD along with the Daratumumab had enough FDA approval. If we look at, this is a randomized trial, and this is exactly the doses what we use in a younger group of patients when we use upfront VTD. Next slide, please. This trial, not just improving the PFS and looking at overall survival rates, it also looked at an MRD. It showed a deeper MRD responses when we used a DARA combination with VTD. Next slide, please. So this has been predicted. So this actually gave an approval for the upfront acceptance. Next slide, please. So this is where we are in the landscape, coming on this newer agents into the upfront setting. Next slide, please. So Daratumumab, the biggest problem in Western countries and for us is the longer time of infusion time. So the new trials are coming up with a subcut Daratumumab, but there's a local reaction, hence they're combining with hyaluronidase and trying it. So along with a multiple combination, mainly a VMP along with a subcut Daratumumab, a phase 2 trial is ongoing. And also there are new drugs with a different CD38 antibody. Next slide, please. So there are other antibodies targeting myeloma cells is elotuzumab. It's another humanized immunoglobulin G1 monoclonal antibody. Again, it's the SLAMF7 protein. And another MOR202, which is a bispecific antibody targeting CD38 along with CD3. And isatuximab is another monoclonal antibody, again as CD38, but it's targeting a different amino acid sequence. And this drug has been studied in phase 2 trials now extensively in combination with pomalidomide. Next slide, please. So managing myeloma, where we are going now. Next slide, please. So if we've got a new patient with a multiple myeloma, first thing we look at is the patient symptomatic, asymptomatic, smoldering. If they need a treatment, are they transplant eligible, non-eligible, and then we plan the treatment. Next slide, please. So this is a recent study. We looked at a lot of trials, Griffin trial, Cassiopeia trial, looking at the DARA combination, but these are the new trials looking at a triplet versus doublet in elderly patients where there is a more toxicity, that is DRD versus RD, and VTD versus DARA VTD in a younger patients, which has a significant difference in CR rates with 78 versus 83% in a younger patients. This article has been published in American Hematology Journal and is published by Vincent Rajkumar. Next slide, please. And looking at all the studies, the recommendation, the overall gist of the things are that DRD, that is Daratumumab in combination with lenalidomide dex, compared to a triplet agent, it showed a 32% reduction in the risk of progression of disease and the progression of death in combination. So it showed a reduction in 32% of risk. And in patients, it showed a less than reduced 52% less risk with a DRD compared to Velcade and dexamethasone. So it gives a significant PFS and overall survival, but reduces the risk of complications, especially in transplant ineligible patients where the Velcade is quite toxic. Next slide, please. So this is a standard flow chart. There is one new information. What you could see is all of us know that we classify the patients eligible, transplant ineligible, and we look at whether they're standard risk and high risk. Currently, the standard in standard risk patients, we give VRD. Most of us do VRD for 3 to 4 cycles, take them through transplant and followed by lenalidomide maintenance. But what the current guidelines is saying is you don't have to go for transplant straight away as long as the patient can tolerate a total of 8 to 12 cycles of chemotherapy and they're in remission, continue with the lenalidomide maintenance. But however, cryopreserve the stem cells after 4 cycles to prevent non-mobilization at a later date. But in a high-risk patients, the combination of DARA with VRD for 3 to 4 cycles followed by early transplant and bortezomib maintenance, not DARA maintenance in a high-risk group. And transplant ineligible, we would go for a VRD 8 to 12 cycles followed by line maintenance. In patients who can afford transplant ineligible patients, we could upfront discuss about a DARA combination with a lenalidomide and dexamethasone until the progression of the disease. And we're not clear whether DARA maintenance in these people would be better or lenalidomide maintenance would be better. That would be for future to decide. In a high-risk patients, we would still go ahead with a VRD followed by bortezomib maintenance. Next slide, please. So this is a busy slide looking at NCCN guidelines 2021. We still have a VRD as a standard of therapy for transplant eligible patients, and you could have a combination of daratumumab with a VTD as an upfront therapy. Next slide, please. This is a non-transplant candidates. We're just still talking about category 1 indication of DARA with Lendex as upfront therapy along with VTD. Next slide, please. We spoke about the combination 3 to 4 cycles followed by transplant, and you in a double hit or triple hit myelomas who are high risk. That is, people have got a P53 along with other cytogenetic abnormalities, trisomies. Now, they consider them as a double hit or triple hit in a high-risk cytogenetic areas and give a DARA combination with a VRD followed by Velcade maintenance. And in patients with acute renal failure, VCD or VTD is recommended along with a high cutoff dialysis. There has been some concerns about the dialysis, but now it is a clear-cut recommendation to do plasma exchange. And VTD has got a slightly better advantage than a VCD in a renal impairment. In plasma cell leukemia, of course, the VDT PACE is the treatment of choice. Next slide, please. Autologous stem cell transplant, definitely, sorry, there's a typo. It's a PFS of 12 to 18 months. There is no change in overall survival. And early transplant versus delayed transplant, there is no difference in survival. And a standard risk, autologous transplant could be delayed if preferred. And this is what the current recommendations are. You could wait on the transplant if patients are doing well, harvest and cryopreserve and move on to the next 8 to 12 cycles in total. Next slide, please. There is no role for consolidation. It is very clear now. Next slide, please. Maintenance therapy, if they're standard risk, you would go with a lenalidomide maintenance for two years. And there is a slightly 2 to 3-fold increase in the risk of secondary cancers. In a high-risk patients, you would go with the bortezomib maintenance every 2 weeks. Next slide, please. So we all know that once the patient starts to relapse, we have a shorter and shorter PFS as we go further on to the second and third relapses. Next slide, please. And we can look at overall survival in these patients. If somebody has relapsed twice, that is a relapse refractory, we could talk about survival 6 to 10 months. And you would definitely need a newer agents to rescue these patients. Next slide, please. So whenever somebody relapses, what we are looking at, there are three features. What are the tumor features, host features, and what is the previous treatments? Tumor features, how rapidly the tumor is increasing, what is the disease burden, is it extramedullary bony disease or medullary, what are the cytogenetic risks? We should always do cytogenetics at the time of relapse, and it's preferable to do a gene expression profiling, especially patients who are moving on to the new clinical trials and the CAR treatments. And looking at whether they are relapsing with a plasma cell leukemia or not is an important feature. And looking at how good the host performance is, age, comorbidities, and bone marrow reserve. And looking at the treatments, how far the previous treatment is, whether they had a transplant or not, whether they failed IMiDs and proteasome inhibitors, what are their response to previous therapy, time from the previous, and all these, looking at the novel options and what clinical trials are available is something what you would start to think about. Next slide, please. So when somebody relapses, a frank clinical relapse, you have to treat them. If they're completely asymptomatic and only a biochemical relapse, we could still wait and watch and work them up every 3 months monitoring. But if they've had no clinical relapse, but there is a significant biochemical relapse, it's very clear cut if serum M protein more than 1 gram, separated by 2 months gap, if we've documented that, or urine M protein more than 500 milligrams, or a free light chain increase by 25%, we should start thinking about retreating them and consider them as a relapse. Next paragraph. So first relapse, we were thinking, are they Len refractory? Or are they not Len refractory, to decide on the next line of treatment? Next slide, please. And in the subsequent relapses, of course, we're looking at a newer agents, PD-1 or selinexor or venetoclax or anthracycline containing regimes, are the new CAR-T and the BiTE. Next slide, please. So this is a relapse refractory multiple myeloma NCCN guidelines. It's a very busy slide. Looking at what we have used previously, we should not be using. At least we should have 1 new agent, ideally 2 new agents in the regimen. That's how we have to choose the regime. Next slide, please. So these are the new trials in a relapsed setting. That's mainly looking at apinabinostat with Dara Valcade Dex versus Valcade Dex, approval of Daratumumab in these relapse refractory settings. Next slide, please.
Padmaja, can you conclude in a minute?
Yes. So I want to show one slide that the patients who are refractory to lenalidomide and Valcade, the 3 agents what we've got is a DPD and pomalidomide, elotuzumab. Next slide, please. So other approved FDA drugs, selinexor, panabinostat. I'm not going to go into the details of this. Let's next move on to the next slide. So I want to show you that there is loads of phase 1 and phase 3 trials looking at a CAR-T and addition of venetoclax with bortezomib and dex, and also PD-1 blockers and BCMA and bispecific T-cell engagers, that AMG 420. They're all in lots of clinical trials looking at new molecules. Move on. Next slide. Next slide. Next slide. Next slide, please. So looking at what are the new agents in the pipeline. Next slide. Next slide, please. Next slide. These are all the combination of daratumumab with the PD-1 blockers, with azacitidine. All these newer agents are coming, and a lot of cellular therapy. And we want to talk about the nanoparticles, how this has been doing. And these are the new monoclonal antibodies. Next slide, please. This slide, please. Next slide. Next slide, please. So nanoparticle delivery is a new approach. So we are going to capture these doxorubicin, carfilzomib, bortezomib into the nanoparticles. Previous slide, please. Into the nanoparticles of lysosomes or a carbon micro or active targeting or by triggered targeting. This is a very fascinating thing, to deliver the drug right at the doorstep of the cancer cell with a nanoparticle. And this could be any agent which is packaged into these nanoparticles. Next slide, please. We just spoke about what drugs can be packaged into the nanoparticles. Next slide, please. So it's a busy slide looking at heterogeneity of multiple myeloma, different pathogenic mechanisms, which one to target. Is it a lineage dependence, clonal dependence, and what agents, microenvironment, which one to target. Next slide, please. And there's different signal pathways in myeloma which new drugs will affect. It could be an F-kappa B pathway or cell cycle or DNA repair mechanism or epigenetic dysregulation. Next slide, please. Or it could be a change in bone marrow microenvironment with a complexity between osteoclasts, blasts, and the the T cells or macrophages, a complexity in the dendritic cell, a bone marrow milieu, which is causing the changes. Next slide, please. So it could be signaling pathway, or it could be microenvironment, different agents. Myeloma is a heterogeneous. How do we separate these heterogeneous patient population and give them a precise precision medicine? That can be done by genomic profiling in a whole genome, whole exome targeted sequencing or microRNA, or using proteomics or mass spectrometry. We can separate out these patients into different subsets and target the treatments according to them. Next slide, please. So this is a clinical trial, MyDrug trial, which is looking at exactly what we're talking about, separating them out in a sequencing platform and giving them a targeted treatments. Next slide. In summary, we have got a change of triplets to quadruples and using monoclonal antibodies, different monoclonal antibodies emerging, and therapeutic landscape is rapidly evolving, and we've got lots of new molecules, immunotherapy, small molecules, concept of precision medicine and nanoparticles is coming on. And a new thing is about a CAR T cell therapy. It could be due to the BCMA or bispecific antibodies with a T and a CD38. The high burden of symptoms and complexity of multiple myeloma patients, they need a holistic approach and they need a specific care in a specialized centers. And we want to give them precision medicine and achieve a MRD as early as possible and continue to have a negativity and restoring the host anti-multiple myeloma immunity. So that would be our long-term goal, to have a disease-free survival and a potential cure. Thank you.